Thank you all for joining us. This town hall about vaccines in a setting of our COVID pandemic is vitally important for our community to know, as well as for you to have an impact on the sphere of influence that each one of you may have and will have. I was just discussing with some of our leaders and experts who I'll deviate in that statement to say we are blessed and fortunate to have some of the brightest minds and most capable physicians, scientists, leaders in the country. And so we're thankful for their participation, their guidance, and their commitment to basically save lives in our community, but also to be really leaders for our medical community as well. But as discussing with them, there are very few things that we have in the armamentarium of taking care of patients who have SARS-CoV-2 that can speak about 90% efficacy. Most of them are far from it. And so what you will hear today is some powerful information about this vaccine, what it can do and what we do know, and what the potential of what it means of breaking the pandemic. To that end, I've asked Dr. Jeannie Marazzo, who's our division director for infectious disease and has been in many ways with others on this call, the voice for reason and information around COVID for America. Dr. Mike Sag, who's our Associate Dean of Global Health, head of our HIV infectious unit, who also has served that role in many ways and has had a passionate voice because of his own personal experience with COVID. Dr. Paul Gepford, who really is the leader of our vaccine center, who's helped us work through a number of trials here and also is working as a leader of trials within the country. And then Dr. Letitia Lopre, who's also an infectious disease member. So I'm not biased against any divisions in medicine or any departments in the school. We could have had pulmonologists as well and surgeons, but I wanted these individuals because of the realm they play. Letitia understands the realm of health disparities as it relates to this disease and the vaccine. And then Sarah Nafzinger, who has really been the physician lead for our health community around both taking care of employees and now helping us get this vaccine disseminated in a large volume and safe way to all of our medical community, as well as our campus. So with that said, I've asked Dr. Marazzo to moderate this, and I will turn this over to her. Jeannie?
Yes, thank you so much, Dr. Victors, for your kind introduction, and I want to acknowledge your exemplary leadership during this really challenging time. So thank you so much for being so steady and so inspiring for all of us. Let me tell you how this is going to play out. We're going to take about the first 20 minutes to give each of our panelists a chance to give a perspective on a particular dimension of what we've been experiencing with this pandemic and where we are in the context of delivering this vaccine. And then we're going to spend about 20 minutes covering some of the many questions that you all have submitted in the last week. So with that, I'm going to go ahead and get started and reintroduce Dr. Michael Sag. Many of you know Michael Sag. He's been a very public and articulate voice during the pandemic. And Mike is the Associate Dean for Global Health and also a professor in the Division of Infectious Disease. Mike, can I turn it over to you?
Sure. I won't take a lot of time, but I do want to give us a little bit of a perspective of what this epidemic is doing. And as I do so, what I'd like everybody to think about is, where would we be if the vaccine studies had failed? That's the thesis. Because we're heading into a heavy storm. It's like a hurricane, gale force winds, whatever metaphor you want to use from weather. We're in a tough time right now, and it's only going to get worse. So I might share my screen real quickly and bring this up. This is what we've been up against. So back in March, I became infected right about March 13th, and it was horrible. I can tell you firsthand, nobody wants this. And I'll spare you the gory details. I did not have to go to the hospital, but I was that close. Unfortunately, it went. But this is the kind of slope of the line of what we had then. And then we had our lockdown, and it worked. The number of cases plateaued, we flattened the curve, and then we kind of, after Memorial Day, got a little lax and started picking up. But it's this ladder curve right over here. That's what we're in now. We have 200 cases in the hospital right now at UAB. It's predicted based on Suzanne's Judd Judd's numbers, that we could double, the whole county could double our cases in the next 2 to 3 weeks in the hospital. So we're in a tough time. I'd also like to give this perspective. We look at all the wars. I grew up in the time of the Vietnam War, and I remember Walter Cronkite coming on TV every day and saying to us, there's 300 people who died this week in Vietnam. And we're seeing that the total number of wars is 101,000 in the last several decades, and we already have gone past. Now it's 310,000 deaths. It's hard to keep the slides updated. But if you look at other wars, pretty soon, I'd say by probably the end of January, we're going to be at the numbers, maybe earlier, of World War II. And remember, that war lasted over about a 5 or 6 year period, and we're talking about a 10 to 12 month period for COVID to hit the same number. And then the Civil War, this is both sides of the war, 655 Americans lost their lives in that war. And I think before this is all said and done, we have a risk of exceeding that. And then finally, this is from last week, but yesterday there were around 3,400, 3,500 new cases of COVID deaths in one day. And just to remind you, 9/11, which changed our lives in major ways, we've exceeded that in our daily death toll every single day. So what I'd like us to think about as you hear about the vaccine is, how does that rescue us? And in many ways, for those of you who remember Greek tragedies, there was the protagonist who would get in trouble, and the gods would come in and rescue them literally with a machine and pull them out of harm's way. And we are in the season of miracles right now. And this is, I think, a modern day miracle, what you're about to hear. And I don't think I'm exaggerating, because when we think about how this might play out if we did not have a vaccine, I don't know if I personally can comprehend it. And I think we all should be thinking about that concept as we think about what a vaccine can do for us. Nobody would recommend a vaccine if it wasn't effective, and certainly nobody would recommend a vaccine unless it was safe. And I think as you see the data unfold before you, you'll see that these two vaccines hit both criteria pretty well. So Jeannie, I'll turn it back to you, and thank you for the opportunity to provide a little bit of context.
Thanks so much, Mike. Those slides are really sobering, especially you can't really keep up with the numbers, which is really, really sobering. So I am going to now turn it over to Dr. Paul Gepford. And as Dr. Victors mentioned, Paul is also a professor of medicine in our division. He's actually the Ed Hook Endowed Professor and runs our Alabama Vaccine Research Unit, and has been a really, really effective leader in this space for a while. So Paul, go ahead, please.
Thank you, Jeannie. What I'd like to do is just talk a little bit about how vaccines are developed, and with maybe a focus on why the COVID vaccine was able to be developed so quickly. So just a little bit of basics. When you have a pathogen that we see, in order to develop a vaccine, you have to figure out which part of the pathogen is something that you want to present to the immune system to vaccinate with. And remember that for the most part, modern technology has allowed us to try and figure out which part of the coronavirus may be useful to develop an immune response against. And this actually was figured out with SARS-1 back in 2003 and shortly thereafter. They figured out that the spike protein was the Achilles heel of coronaviruses. And so when this SARS-CoV-2, which is the coronavirus that causes COVID, came along, the scientists already knew what to target. And so the spike protein is just one part of the virus. And just that one part, you obviously cannot get COVID from that one part of the virus. But how does the immune system figure that out? Well, what happens is it's the part of the virus that is easily recognizable to the immune system. And then they know when they see the virus that is COVID and I need to kill it. And it's sort of like if you showed me your keychain to your car, I can tell you what make of car you're driving. I don't have the whole car, but I can see it. Now, it's important to have the right part because, for instance, if you just showed me the hood of your car, the wheels of your car, maybe I couldn't recognize it. But you have that part, which is the keychain of your car that has, let's say, the Mercedes-Benz emblem, then I can figure that out. So that's the first thing that they got on that very quickly. They knew that it was the spike protein that was the important part to use as a vaccine. The second breakthrough in technology is this messenger RNA, which has never been used before for vaccines. And the reason this is important is you can make this very quickly into your vaccine. And the Chinese actually shared the sequence of SARS-CoV-2 or COVID very early in January. And within a week, the NIH with the Moderna vaccine and Pfizer were already making the vaccine with their mRNA technology. That's very, very rapid. And the reason mRNA actually has worked so well is because it actually uses muscle cells from the vaccinated individuals as protein factories. So then it makes the protein that then actually gets recognized by the immune system. And so you just have to give it the genetic material to make that protein. And so as we will talk about, Moderna and Pfizer, their mRNAs have been wildly successful in the immune system being able to recognize those proteins. And so what happens is now you have an immune system that's trained. It recognizes the protein. And then when in the future, if somebody actually gets attacked by the coronavirus, by COVID-19, the immune system immediately knows that this is a foreign invader and it destroys the virus. And that's how these vaccines work. So why is it that older technology has not been used so far? And that's because it takes longer to develop older technology into a vaccine. And the reason for that is you have to take the genetic material, you then have to grow the protein in a test tube, then you have to purify that protein, then you have to take that protein and then use it as a vaccine to vaccinate somebody. So it's a much more complicated step. And whenever you do something outside of nature, it's more difficult to do. And I will tell you that all these protein-based vaccines, even though they're being developed, they still haven't even started efficacy studies. So that's one of the big reasons why we have been able to rapidly develop these vaccines. I'll end with a couple of things. First of all, we are very indebted to the community because they have volunteered tremendously to do these studies. About 150,000 participants have volunteered for these studies across the 4 trials in the United States. And when you get so many people in these studies, you can get a very quick answer to whether the vaccine works or not. And sadly, because we've had such high rates of infection, you're able to get the endpoints much more quickly. And that's another reason why we've been able to have an answer so quickly to determine whether these vaccines work. And as you know, the Pfizer and Moderna vaccines, as Dr. Vickers has mentioned, work at 95% efficacy. So that's all I have. Thank you for your time.
Thank you, Paul. And we'll come back to you as a number of people have had some very detailed questions on how the vaccine works. Is it safe and is it effective? So don't go away. I want to ask Dr. Letitia Alopre to make a few comments. Letitia is assistant professor in the Division of Infectious Diseases here, and also has, as Dr. Vickers said, has a long history of strongly advocating for excellence in diversity achievement, and has received the Dean's Award for that honor. So Letitia, please, over to you.
Thank you, Jeannie. I think, as the other panelists have said, I've been in awe over the achievements that we've made scientifically in being able to roll out such an efficacious vaccine in a short period of time. And I think from a public health standpoint, what most people are concerned about is this idea that we're not going to get the coverage needed to really see the benefits of this vaccine, and this idea of vaccine hesitancy. So ultimately, what we're facing right now is a community of individuals who are very concerned about the safety of the vaccine. And I think as scientists, it's hard sometimes when you have such an efficacious pull to not understand why people would be willing to take it. And I think what my main point in saying today is that I think we have to take a step back and realize that a lot of the points that people are making and the fact that people are hesitant is valid. And that is due to a history of institutional distrust. So when we have communities that are having to overcome serious barriers related to their culture, socioeconomic status, and political beliefs and barriers, it leads to mistrust and can hinder uptake ultimately of vaccines. And we've seen this in other settings as well in other countries when we try to have anti-malarial programs in African countries that were ultimately unsuccessful due to distrust at the community level. There was actually a wonderful publication in Lancet that talked about what we could do to try to overcome some of this distrust. And it required, number one, a tailored approach, understanding that communities, especially communities of color, will have differing beliefs and need differing messaging related to that, and that it has to happen at multiple levels within our government and our local municipalities. So they really called for on a national level having a clear, unified message and funding to support local governments in rolling out informational campaigns that really answer the questions that community members right now are having about the vaccine. And one of the key things that I really enjoyed and I think is necessary that was pointed out in this paper is that we have to have community engagement. So understanding that from a government standpoint or from a healthcare standpoint, there are different layers of trust that we may not have, and going to communities and talking to their leaders and people who are already trusted within those communities might be the key. So talking to potentially religious leaders, people who are teachers, who have history working within the communities for long periods of time, answering their questions through multiple forums like town halls, and helping them to understand how safe the vaccine is, and helping them to answer questions for people within their community. And then also tapping on those leaders to help us shape our educational campaigns that roll out to make sure that they are culturally relevant and are actually having the impact that they need. So I think ultimately, when we're having conversations on a one-on-one basis, and people are saying that they are hesitant to take the vaccine, recognizing that that is something that is valid and that is our job as healthcare professionals, scientists, and providers to become trustworthy and make sure that they understand how efficacious this vaccine is in language and words and through a messaging campaign that has really been shaped by them.
Thanks, Letitia, so much for that and for your work in this really vital area. And I last want to invite someone who's been very important to our system and all of us in the last several months, and that's Dr. Sarah Nafziger. Sarah is a professor in the departments of emergency medicine and neurology, and also the physician advisor for the Center for Patient Flow, and has been incredibly pivotal to not only keeping things running smoothly in the hospital, but is now at the center of helping us all get vaccinated. So Sarah, please.
Thank you very much. I'm going to share with you some of the details about operationalizing what's arguably the most important vaccination campaign of our lifetimes. It has been quite a journey for us over the last few weeks as we've been working to operationalize this. Now, I'm the medical director for our employee health department, and we provide influenza vaccines every year to our employees, and it's on the order of 14,000 vaccinations that we administer over the course of 6 weeks, which is pretty staggering numbers if you think about the rate that we proceed with that. But this vaccination rollout is a completely different challenge. It's been a lot more challenging for several reasons. First of all, these vaccines have specific storage and handling requirements. The Pfizer product has to be stored at -80 Celsius, so that requires special freezers that you can't just go to the store and purchase. So we've been dealing with these challenges, the temperature monitoring challenges, and lots of other logistics to make sure that we can deliver this vaccine in a timely manner. While, you know, we're all very grateful that the vaccine got here when it did, we were all, frankly, a little bit surprised by it. So we thought that it would be after the first of the year. So we had to accelerate the timelines, which is a great problem to have. So we're pretty happy to be working on this now. So the key information that I think is great for you to know when we're rolling out this vaccine and just kind of looking at the operational piece of it is that everything changes quickly. It's been a very fluid situation. I think that's been the best way to describe it. And certainly I feel like all eyes are on us right now as the vaccine has arrived here. Everybody is very interested in knowing when it's going to be their turn. And anytime you have a resource that's scarce like that and you have to make decisions about who gets it first, it's very difficult decisions. We don't take that lightly because I know it's a matter of life and death for some people, to be quite honest, you know. So we want to make sure that we get the vaccinations out in the most safe manner and get it to the people that need it the most first. So fortunately, we do have guidance on how that's supposed to happen. The CDC, working through the state health departments, has issued guidance and a phased approach. And the first people designated to receive vaccine are healthcare workers and long-term care facility residents. So that's the phase we're in now. That's called phase 1A. So as a student, you may be thinking, where do I fall in this? And so students in the education sector fall in phase 1B, which is the education sector. And I'm told by Dr. Mike Faircloth, who's the medical director for student health here at UAB, that our clinical-based students will be prioritized first for vaccine among all students. So that's where students fall in the phasing. So a couple of interesting things about how this vaccine allocation occurred that may be interesting to you in the topics of conversation is, you know, when UAB was elected to receive vaccine, we were selected to receive almost 11,000 doses in the first week's allocation. And that's out of the 40,000 doses that came to the entire state of Alabama. So a little over a fourth of the entire state's allocation came to us. So we're very pleased with that, but it came with some specific directions. We didn't get to keep all of it for ourselves. We have very specific directions to share with others. And of course, we're happy to do that. So a portion of it we're giving to EMS workers, to ambulatory-based healthcare providers from other places. And we're also sharing with other hospitals. So there's a lot of sharing that goes on and a lot of coordination that goes into that work. So when we think about some of the more significant challenges that we face, just picking, you know, it's enough of a challenge to decide which groups get it, but then you have to think down to the details of, well, if you're going to vaccinate healthcare workers at your hospital, who do you start with? So we've guided those decisions with some multidisciplinary groups that have had input, but essentially what we're looking at is that people that have the most risk of COVID exposure at work based on a lot of different factors, like the history of workplace transmission in those units, their exposure risk, the type PPE they wear, the type patients they're caring for, and what's happening in those units. So a lot of things go into that decision making. And as you can imagine, those are very difficult decisions to make. One of the other key challenges we've had is just developing databases and the technology solutions to implement such a massive vaccination campaign. Previously, when we've planned for these with our public health partners, we've used a specific technology platform called Dispense Assist, but at the last minute, the decision was made by State Department of Public Health that we would use a different system called Imprint. So we had to build the computer systems and interfaces to make that data flow work. And it had to happen. It's a project that normally would take about 6 months, and we had to make it happen in 2 weeks. So it's been quite a challenge. Just to give you some context for how big of a project this has been that we've rolled out very quickly. So another piece of this is thinking how you invite employees. And a lot of hospitals, you know, I was reading Mass General decided to have a little bit of an open invitation process. And we decided to be more focused than that. We're using closed invitations where we identify specific individuals and send them an invitation. And, you know, you can make arguments for which methodology you use, but, you know, I like to try to be more controlled so that we can make sure we're equitable in that distribution. We don't want to have, you know, people cutting to the front of the line who probably would be safer if they waited a little bit longer. So a lot goes into the planning for this. But so to summarize, I'll conclude by saying, you know, we're really excited that we're receiving vaccine. We're administering it today. We started yesterday, but we're full-fledged today. I hear that it's going very well. We're really excited about it. we're going to continue to receive more and more shipments of vaccine, and that'll be rolling out certainly to all our healthcare workers, and hopefully we'll be able to get to the medical student population soon. We'll be partnering with Dr. Faircloth in Student Health for that vaccine administration when we get to that point. And so I'm sure we're going to learn a lot from vaccinating our employees. And so the way that works and the way that looks may be a little different by the time we get to that point, but we'll see when we get there. Thanks so much for your attention.
Sarah, I just want to thank you on behalf of everybody. We know you've been working 24/7 on this, and I think for people who are directing frustration or maybe don't understand exactly how these things roll out, please understand that this is kind of like planning a wartime effort in record time. I mean, we didn't even really know for sure these vaccines were going to come until about 10 days ago, right? Because the FDA approval, emergency use authorization, was literally a week ago today. So, I mean, we knew we were going to get vaccines, but knowing that you're going to get vaccines and then actually building out this system are two separate things. So please stay healthy, and we need you, and thank you for being so amazing about this. So really want to thank everybody for those great comments to get us started. We had over almost 300 questions, so I've sort of tried to put them in a bunch of different buckets, and I'm going to direct them. I'm going to start by directing them to individual panelists, but I would love it if others would jump in and add their thoughts, because I really would like this, as would Dr. Vickers, to be more of a conversation than a series of interviews. I think one of the big questions on people's minds, and I'm going to ask Paul to start with this discussion, is Dr. Vickers mentioned this 90%, 95% efficacy. Can you tell us, what does that really mean? What did we see in the studies? And is there a difference between the Moderna and the Pfizer vaccine?
Yes, so thanks for those questions. So the way they do these studies, Moderna enrolled 30,000 people. They vaccinated about half with the actual vaccine, and the other half got placebo. And Pfizer did the same thing in about 45,000 individuals, split half and half. And then you just follow them over time, and you start counting up cases after 2 doses. After the second dose, I believe it was 14 days after the second dose, they started counting cases in both situations. And what happened was that the vast majority of cases for both Moderna and Pfizer, the people who got symptomatic COVID infection, so this was somebody who had symptoms of COVID and then it was diagnosed with a PCR COVID test, that those individuals actually were mainly in the placebo group, the people who did not get vaccine. Now, there were a few that actually were in the vaccine group, but when you do the math, you do the math that there were so few in the placebo group that it's 95% effective in preventing symptomatic COVID infection. Now, there is some data on severe infection, which is what we really want to know. How well does it prevent severe infection? And the problem is the numbers are small there. The numbers were larger for the Moderna vaccine, which hopefully will be FDA approved today. But it does appear to prevent severe infection as well. In fact, for the Moderna product, there wasn't a single case of severe COVID infection in people who received vaccine. The other thing people like to ask is, does it work well in young and old? And apparently it works really well in both the young and old individuals. And then the other question is, does it work in men and women? And yes. Does it work in whites and non-whites? And the answer appears to be yes, although there were less non-white individuals enrolled, but still Moderna enrolled about 30% of non-white individuals. So this is just tremendous news for us. It exceeded our expectations for vaccine. And I've been working on vaccines for 25 years and I've never seen anything like this. So this is just a tremendously effective vaccine. And let's go to safety now. So for safety, remember now, it's been studied in those 2 trials in almost 80,000 individuals. Half got vaccine, half did not. And there are, people will get some side effects with it. Almost everybody gets a sore arm. Some people do get headaches and fatigue. And actually placebo recipients get headaches and fatigue as well, but it's a little bit more in people who get the vaccine. Fortunately, all these side effects seem to be transient, meaning that they go away in 1 day, 2 at the longest. So while the vaccine is not completely innocuous, it does cause some side effects, but we think these side effects are basically telling us that the immune system is ramping up. And obviously it seems to be ramping up in a very effective way.
Yeah, Paul, if I can add, one of the major treatments we have right now is a monoclonal antibody against the spike protein. And so it works dramatically well if it's given in the first 3 to 4 or 5 days after onset of symptoms. And in essence, this vaccine is just kind of creating that monoclonal antibody of sorts endogenously after the vaccination. So there's a common pathway biologically for both of those interventions to work.
Yeah, and I would just add that, just to give the vaccine a plug, giving the monoclonal antibody after you're infected is not nearly as efficient as having it beforehand. And that's why vaccines are so powerful. And in fact, there's data in preclinical data in animal models that show that both the monoclonal antibody does work, both before and after, but it works much better if you give it before any kind of infection. And so therefore, that's why the vaccines probably work so well.
Excellent, great. Any other comments from the other panelists? And if not, I'm going to grab Dr. Sag again, since he jumped in there. And I'm going to say, so you've shared your experience of being infected, Mike, and that's been, I think, a profound help for us to talk with people. Are you going to get the vaccine? And can you tell us a little bit about what the guidance is for people who have had previous COVID and know they've had it?
Sunday at 7:30.
All right.
I'm in Dr. Nassiger's line. I'm already signed up. Yeah, so there are some questions, but typically the guidance is, if you've had the infection before, most everybody has mounted an antibody response, but it tends to wane over the 3 to 4 months after infection. There's variability about that, of course, but after 90 days, people are recommended to get a vaccination or consider it. So that's what I'm doing. And I've donated blood to Dr. Gepford's study ever since the second day of my illness. And so we have not only my antibodies that we're following, as after I get vaccinated, we'll distinguish between the two and we'll see which one's more profound. But Paul, you can comment on this real quickly, but it seems like the vaccine-induced antibody is more robust than the infection-induced antibody. So it's even better.
Yes, that's correct for some studies. So the Moderna and the Pfizer vaccine studies, they show that the antibodies, which, remember, the antibodies are what we think you need to protect against infection, that those antibodies are actually higher when somebody gets vaccinated compared to when they recover from COVID infection. So that's obviously really interesting. And it suggests that these antibodies may last a longer time, but we just don't know that yet. We just don't know how long this protection will last. And we are obviously very interested in continuing to look at that.
Fantastic, thank you. So one more question for Dr. Sag, and then I'm going to bring Sarah and Letitia into it. So Mike, you see a patient who brings their serology result. They were one of these people who managed to get an antibody test, say 3 months ago, and they have evidence of the antibody. What do you tell them? They say, why do I need to get vaccinated? I already have the antibody.
Well, it would be a good discussion to have, I guess, but if it's been more than 90 days, I would say that the likelihood of an adverse outcome from the vaccine, as far as everything we've seen so far, is low. And we don't know how long the immune system response is after native infection. So we do, and finally, we have seen at our place, as well as other centers around the world, people who have had the infection and then 4, 5, 6 months later get reinfected with a brand new episode. So we want to prevent that. So I would advise them to strongly consider getting the vaccine. It's of course going to be their choice, but I would recommend that.
Thank you. And to be very clear, the CDC, ACIP, none of them recommend checking your antibody before getting the vaccine. It should not impact at all. And Dr. Nafziger can comment, we are not offering or asking or planning to look at antibody before giving people the vaccine for that very reason, for the reasons that Dr. Sag and Dr. Overton just outlined. Dr. Nafziger, while I actually mentioned your name, let me ask you a question that we got quite a lot. And that was that it seemed in some of the public material we've been hearing about that pregnant or breastfeeding women may actually get the vaccine. So how are you approaching that here, and what are your thoughts about that?
Yeah, that's a great question. In fact, we were still trying to receive guidance from the CDC and the FDA on this topic as late as Monday, is when we received a lot of the clarifications on this piece. This has been something that everyone has talked about a lot, because the studies that were done excluded the groups of women who are pregnant and breastfeeding. So we have limited data on those individuals. However, the consensus from experts seems to be that they feel like it's most likely safe. And in fact, we have a letter from the Society for Maternal Fetal Medicine, I believe is the name of that group, that advocated for these groups to be offered vaccine and let them make their own decision. So with the guidance of all these different groups and the FDA's guidance, the CDC's guidance, we ultimately came up with a process so that we can provide information that the manufacturers have given us for these vaccines. We're going to give that to all the individuals who are candidates for the vaccine, and allow these women to make their own independent choice whether or not they want to receive the vaccine. So we will offer it. Certainly not mandatory. It's not mandatory for anyone, but we want to make that available and let people make their own decision.
Thank you for that. And I think we should just really take note. It's a pretty historic event when the ACIP and the CDC and NIH say that you can actually do something in pregnant or breastfeeding women, right? The general practice has been one of undue caution, if anything, that's been harmful to women of reproductive age. So to me, that says that there's a lot of confidence in the safety of this vaccine, and really is important. You mentioned the word mandatory. That was something else that people asked a lot. Is this going to be mandatory? You said it's not, but can you just expand on that a little bit, and why, for example, the flu vaccine is mandatory, but this one won't be?
Yeah, that's a great question. A lot of people have talked about that an extensive amount. And one of the reasons is, for right now, this drug is approved under an emergency use authorization. So that in itself was enough to make us feel like we really could not make it mandatory at this point in time. In the future, who knows, it may be mandatory. There's so many things that we've had to learn on the fly with this virus, but for right now, it's not. The second thing is, it's just so new, and a lot of people do have questions and concerns. And I think that's valid. Before we, take any vaccine, we should ask ourselves, is this something that I'm comfortable with the risk of the vaccine versus the benefit profile? And so I think for everyone at this point, it's a very individual decision. I can tell you what we're seeing from our preliminary data so far in employee health is almost everyone that we've invited has elected to receive vaccine. Very few people in our healthcare worker groups, at least, are refusing. So I'm really happy to see that. But that's the logic there, is we just didn't feel like it was time to go to a mandatory. In the future, could that change? Possibly. But right now, the only mandatory vaccine for UAB medicine is influenza.
Great, thank you. That makes a huge amount of sense. So Dr. Alopre, let me circle back to you. Dr. Gepford mentioned that the efficacy of the vaccine appeared to be similar across age groups, across ethnicity, across race, but emphasized that the numbers, particularly of African-American people and people of color, were not as robust as we might have liked in the 2 studies so far that have supported these vaccines. Can you talk a little bit about how we talk to people about that? How do we talk to people in the most vulnerable communities who we would really love to protect against this infection, given the disproportionate morbidity and mortality that we're seeing there?
No, I think that that was something we were all hoping would be a little bit better and more robust, looking at how many people of color were recruited in Pfizer. And there was higher numbers in Moderna, but still, I think not what we were hoping for based off of what we're seeing from an epidemiologic standpoint and how the disease is being spread. I think ultimately what I've been trying to emphasize is that we know that this pandemic is not affecting communities equitably. And so for communities of color, specifically African American and Hispanic communities at this point in time, this is one of the best options we have in protecting those communities. And I think we just have to keep reiterating that. And then again, understanding that it's going to be not just one conversation or informational sheet, because as you can see from this forum, there are tons of questions that are being asked. It's going to take multiple conversations and having champions within those communities, because talking to my mother about whether she should get the vaccine or not, my opinion alone isn't going to change her behavior. And there's theory to back this. It's going to be the attitudes and beliefs of those within her network that's going to change her behavior. So getting her friends, her boss, her religious leader to get on board, I think is what's going to be most effective, especially in vulnerable communities.
And how do we do that, really? I mean, how can we help do that? I think that's the really big question, because we are really good. I'm really good at, I can't say we, but I'm really good at talking a lot about it. But I guess, when the rubber hits the road, we would do everything we could to make it happen. It's a question of how we do it.
I think it's, twofold. Really, I think it's going to take, again, getting these champions within these communities that we know are already trusted and answering their questions, because they're the ones that are really tapped in, our opinion leaders that are going to, I think, push change of behavior within rural communities like Lowndes County. It's not going to be someone from UAB coming in and talking with those individuals. The other thing that's important is that when we're rolling out these programs with our actions, showing that the way we're rolling it out, number one, is transparent and also equitable. We as an institution, we as a governing body have to show that we are also invested in making sure that these types of efficacious vaccine programs are being distributed within vulnerable populations, and that they are at the forefront of our thoughts when we're talking about trying to end the pandemic. So I think we have to back it up with our actions as well.
Dr. Vickers, did you want to comment? I see you're very interested in this topic, of course.
Yeah, I agree with everything Letitia said. I think she's spot on. In fact, Jeannie and I did a small segment trying to reach that part of the community to give understanding, but also to encourage each person, as I mentioned when we started this call, has a sphere of influence. And I think what I stated in that setting is that all of us have areas where we have limited knowledge. And let's just call that, in some ways, we have some ignorance about space that we don't know. But most of those spaces don't affect our lives, whether it's being on a rocket or in a submarine, for an example. I'd have fears about both of them, but I don't have to face that on a daily basis. But medicine is a black box for many people for multiple reasons. Either they don't have access, there's historical distrust, and as Letitia said, there's past missteps and mistakes that have created that distrust. So that black box then creates that level of just not understanding and disbelief, but it's compounded with this fear of this pandemic and this virus. And it's very powerful to create actions and attitudes that may not seem logical. But I think we have to work to uncover the black box of medicine by the care we have for those communities, by using the people you've talked about, Letitia, to be the voices of reason. And we have to remind them of the damage that this virus has done. It seems in some ways to have been more preferential in its damage in those communities. And we can't not do that without making them aware. We want to avoid further carnage because this vaccine seems to work across all races.
Thank you, Selwyn. That's great. I want to make sure we have time to cover two areas, and they're actually related to this trust issue and the black box of science, because sometimes, of course, the messages that get out in the media are not necessarily very subtle. One thing we've been hearing a lot about in the last week are the anaphylactic reactions in healthcare workers, right? There have been now 2 healthcare workers in Alaska, one of whom was hospitalized with supposedly an anaphylactic reaction, one of whom didn't really have an anaphylactic reaction. For those of you who don't know what that is, it's just having hives, urticaria, trouble breathing, not good things, life-threatening. And then there were 2 in the United Kingdom. So people have been emailing me to say, you know, I had hives when I had shellfish about 10 years ago. Should I get the vaccine? I sometimes get a rash when I eat peanut butter. What should I do? So anyone can answer. Paul, maybe we'll start with you and others can jump in. It's really handling this history of allergic reactions, and also what do you think about those cases?
So there, I think right now it's recommended that people who, if they have a severe allergic reaction to any vaccine, they probably shouldn't take the COVID vaccines. However, if they've just had an allergic reaction to something that's non-vaccine related, it's probably safe to take it. And the reason for that is that most allergies are very specific. They're very specific to a certain antigen or to a certain particle. And it's unlikely that having hives to, let's say, seafood, there's no seafood in these vaccines or anything like that. And so it's probably safe. Now, I'll just say parenthetically that remember that some people can have true egg allergies. So if you have anaphylaxis to eggs, you can't get the flu vaccine, because at least a type of flu vaccine, because those are actually grown in eggs. But the COVID vaccines aren't done that way. They're grown in cell cultures. So it's only people who have very severe allergies to actually prior vaccines that should not get this vaccine.
Thanks. Thank you. Any other comments on that? One thing I did read was that the nanoparticle that encases the messenger RNA has polyethylene glycol, or PEG, which is a preservative, and that actually is something that can provoke allergies. And there's some thinking that may be responsible for the anaphylaxis, but I'm not really sure if that's the case. So I think what you said, Paul, about if you've had an anaphylactic or serious reaction to a vaccine, that's when you should think twice about getting this one. So I think that's really important. The other big question is immunocompromised populations. So what if you have somebody who is on a monoclonal antibody for an inflammatory condition, an autoimmune condition, somebody who has one of those conditions? What do you think about that?
I think the risk
Yes.
is not so much that
Sure, Mike, go ahead.
Yeah, I'm sorry. I think the risk is not so much that there'll be an adverse reaction as much as a concern that the immune system may not respond in as robust a way as we would like, because it might be suppressed. But on the other hand, if you weigh that out against getting COVID in the setting of immunosuppression, we know that there's a higher risk of bad outcomes. So I think the vaccine might especially be recommended for people who are immunocompromised. And Sarah's mentioned already that in the waves of rolling this out, that group of individuals will be prioritized for those reasons. If other people want to comment.
Yeah, I would totally agree with what Dr. Sag said. It's not unsafe for somebody who's immune suppressed to get this vaccine. It's not a live attenuated vaccine. Remember, as I mentioned before, it's just a particle of coronavirus. It can't cause coronavirus. And the only danger is that they may not respond to the vaccine, but some of them actually will respond, and it will probably help them. And then this gets to the fact that it's so important that we achieve herd immunity or community immunity, because that way, if all of us who can respond to the vaccine get the vaccine, then we can protect those who are most vulnerable in our community. Because there are many people who just will not respond to the vaccine, and they're going to remain at risk, and we need to sort of put a shield around them of protection of other community members.
Paul, as a card-carrying virologist on the panel, a lot of people are wondering if the virus is going to mutate. So am I going to have to get a new vaccine next year for one of 2 reasons? 1, because my antibody doesn't last, and 2, because the virus mutates.
That's a great question that doesn't have an answer. So both things are possible. I think only time will tell. There are certainly, the virus has mutated somewhat, but whether it's mutated as a result of immune pressure, it's debatable. In fact, there's no evidence of that. Right now, it seems to be one virus that the vaccine will actually cover. So for that point of view, I think we're okay. in terms of how long the antibodies last, we just don't know. There's some data that the Moderna vaccine does seem to last a fair amount of time, although we only have data for about 3 to 4 months after the vaccine, so only time will tell.
Okay, thanks. I know we're getting close to the end of the hour, but I want to try to get a few more questions in. Dr. Knapsinger, let me ask you a question that has come up a lot. And that is, what about availability for the vaccine for people under 16 years of age? I know that you are hopefully not employing children, you're not violating child labor laws, but I know you've been really thinking hard about this and wondered if you could comment on that.
Yeah, that's a great question. You know, we were thinking initially that the EUA approval might be for folks 19 and up. So I was glad to see that it was approved all the way down to age 16, but I really don't know how we're going to handle that. I'll be honest with you. I'm going to have to say I just don't know. I've really been thinking about it more from the adult perspective. I know that from the student health perspective, they were struggling with it, thinking they would be cut off at 19, as many of our students here are 17 and 18 years old. But frankly, I don't know how we're going to handle that. I think that is yet to be determined. My hope is, you know, as a parent, my hope is that it'll be handled similar to the pregnancy issue, and it will let the individuals make their own decision rather than restrict them from receiving vaccine. But I really don't know how that's going to play out yet.
Yeah, that's a great point. And I think two related comments. One is that it's a reminder that, you know, we don't just treat our employees, we treat everybody in their family. We're all connected, right? So if your kids can't go back to school or your kids are sick, you can't come to work, you've got to so we're all greatly interconnected and it affects us. The other thing I'll make a comment is Paul and I are both involved in the vaccine treatment evaluation units. And right now, both Moderna and Janssen, you haven't seen the results from the Janssen vaccine. I may ask Paul to comment on that because he's leading that study here. They are both very avidly developing protocols for research, clinical trials in pediatric populations. And we're thinking those are probably going to start in January. The idea is to try to get some data so we can inform a vaccination campaign that would protect kids in time to get back to school in the fall. That's the idea with that. So Paul, did you want to say something, please?
No, I agree with you that those companies are working on developing vaccines to show the safety and efficacy in vaccines in pediatric populations. And just back to herd immunity, we really would need those individuals to be vaccinated in order to achieve full herd immunity.
Okay, thanks. I want to go back to Letitia just briefly. I know we started late, so I got the okay to go just a couple minutes longer. I hope that's okay. Letitia, a lot of questions about what tips do you have for those of us in healthcare who want to respond to our families and friends when they say not only they don't plan on taking it, but they're suspicious of whether the vaccine was created as a way of government control or as a way of affecting vulnerable populations? How do you handle those sorts of conversations?
So unfortunately, I've had multiple conversations where people have been very distrustful, asking if they were going to get COVID-19 from getting the vaccine and other infectious diseases, even HIV. And honestly, I've been trying to approach it, making sure that I'm not responding in a judgmental fashion and understanding that a lot of these questions and concerns are coming from an area of historical racism and damage that has been done in this country that's led to this distrust. So when I communicate with people, I try to understand and try to validate their feelings, saying, I understand that that is something you would be concerned about. Can you tell me a little bit more of why you're concerned about it? And then really make sure that I'm trying to be as responsive as possible to all of the questions that they have. Because as Dr. Vickers nicely said, we have to change multiple people's opinion in order to have these spheres of influence change. So us being judgmental and getting angry and saying, I can't believe you believe that, you're hurting the mission of us getting herd immunity, is not going to help change those opinions and change those areas of influence that we need to change.
I can't agree more. I think handling skeptics respectfully is really, really one thing we've learned with vaccine hesitancy in general. Last comment I would love this is an interesting question, and it gets to the trust issue and the mechanism of how these vaccine works. Because I've heard people say, is this like gene therapy? Is this going to mess with my DNA? And could we potentially see a persistent RNA infection in people who get the vaccine, so that you might eventually be more likely to get the virus? And Paul, maybe I'll ask you to address that. I thought that was interesting.
Yeah, so it's not gene therapy because we know that giving this mRNA is just transient. Remember, you have to keep this at -70 to -20 degrees Celsius, because if you don't, it dies quickly. It turns out when you give it to the body, it goes into muscle cells, it gets expressed, it expresses the protein, and then it quickly goes away. And remember that muscle cells that express the spike protein, they will likely get destroyed by the immune system as well. So there's sort of two mechanisms whereby these things don't persist. Gene therapy requires that you actually take the genetic material and integrate it into the host genome. And this, I don't know how to say this in exactly layman's term, but it never gets integrated, it never gets into the host genome. It stays out in the outer part of the cell. So really, it's not gene therapy.
Great. I think that's really important, especially because, as Dr. Vickers mentioned, the cellular machinery is not something that's in the front part of everybody's brain every day. So it's kind of hard to describe that. Sarah, I did want to ask you, if you don't mind, and then I think we should probably wrap up. I do want to remind people this is going to be recorded, and a recording will be distributed. So if you had to leave early, or you came on late, or you didn't catch it, you'll be able to catch up with this. Sarah, could you say a word about what we're anticipating with the Moderna vaccine? Do you think we will get it pending what the FDA decides? Probably tonight, I would guess, if they're going to make a decision based on yesterday's meeting.
Yeah, so actually, those of you have probably noticed that I've been sitting here looking at my computer screen, multitasking during this webinar. I apologize for being so rude, but what I've been working on is working on details around the Moderna allocations, because we do know that some facilities in our area have been allocated Moderna. And so we're working on the details of how we're going to allocate and distribute among the different hospitals in town, and make sure that we maximize and get the doses where they need to be. So we do anticipate that there will be some in the area, and we're working to figure out how that's going to happen. It's a very complex math, and most of this we've been finding out just at the last minute and having to really scramble to try to flex to what we're being given. So yeah, we do think it's coming. As long as the approval happens, I think that it will, and we'll have both products on the market in our area and available to many of us quite soon.
Thank you.
Jeannie, just as a simple comment, and I think you could confirm this, that there is no ability that once you get one of those vaccines to cross over and get your second shot by another vaccine. So if you start down the road of Pfizer, you need to make sure Pfizer is your second dose. And if you get Moderna, Moderna should be your second dose as well. Am I correct?
Absolutely. That's just what I was going to say. Absolutely. Thank you. Thank you for that. Well, I think we should probably wrap up. I was going to ask if any of the panelists wanted to make any final comments, and then turn it back to Dr. Vickers for his final words. And really want to thank the panelists and all almost nearly 1,000 people that we had here today participating. So thank you so much.
Jeannie, thank you. This is exactly what I think we wanted to see. I am glad that nearly 1,000 of our participants coming from our medical center were able to hear from our experts. I think one of the things that Jeannie said in another setting that is also fits with what Mike has said. We're all talking about the vaccine and what it needs to do and what it will do and can do. But we need to be also mindful of the lives that have been lost and the suffering of how these lives were often lost alone. It's probably not like anything we've seen, where so many who've died alone. Mike showed you the numbers related to the war. Many a times those guys were dying next to their buddies. Unfortunately, so many of these people were dying alone, only with their surrogate families, who was the nurse or the respiratory therapist or the doctor who happened to be there FaceTime in their family. So there is a human tragedy side of this of significant proportion, which I think also needs to bear on our willingness to hopefully get people to understand the step up, as well as to understand how fortunate we are during this holiday season that the vaccine experiment did not fail us. It's worked well, and we will do all we can to bridge the gap between the vaccine and the vaccination to make sure people can get it. Thank you all, and thank you, Jeannie, Paul, Letitia, Mike, and Sarah. And our communications team, Jessica, Paige, and Mary Ashley, thank you for setting this up and the great work that you do.
Thank you all. Bye.
Thank you.